Okay, let's go over Svetlana's case review. So, we know she has Parkinson's disease. That's her main chief complaint. She's 61 years old. And if you look at the list of chief complaints, number one, she writes Parkinson's symptoms, progression, and now she's having progression of dystonia from Parkinson's disease and or PD medications. So dystonia is basically dysfunctional tone. So usually it becomes very rigid, and you can get angulations. It could be of the arms, of the legs, it could be of the feet, it could be of the head. So we want to figure out specifically where she's feeling her dystonia. Is it cervical? Is it her foot? Is it her hand? She says extreme strong rigidity in off low dopamine states, mostly on the left side. So when you look at someone who's got Parkinson's disease, they usually start on one side and then progress to the other side. They actually usually start with one limb, then progress to the lower limb or upper limb on the same side. Then they go to the other side as they progress. So if she's only having left-sided symptoms, then that's pretty good for us to know. So she reports she's having off days. When you look at people that have Parkinson's disease, they're always playing this balancing act with their medication, and they look at what's called the Goldilocks effect, where they're trying to get the right amount of medication in, where they have efficiency of function. And if they take too much medication, they can get symptoms develop, and if they don't take enough medication, then they don't have resolution of their stiffness or rigidity, and if they have tremor, that could be an issue. Now, she's also saying she's recently developed anxiety and panic attacks. They are often sudden, unexplained, and manifest as totally akinetic state and inability to move. Akinetic, A meaning inability, kinetic movement. So it's basically like freezing. So something is definitely impacting her neurological pathways from that limbic frontal loop here. And then she also puts, I noticed that all kinds of excitement, bad or good, cause anxiety. And, once you're dealing with catecholamines and some of the medications she's on, and as things progress, some of these things are common to develop with patients that have Parkinson's disease, in addition to insomnia. So those are her main chief complaints. Her main chief complaints is looking for some strategies to help with their Parkinsonian pattern. Now, there's no cure for Parkinson's disease, and before I even accepted her as a patient, I had a quick call with her and said, hey, listen, Parkinson's disease is a progressive, 100% progressive disease. You're for sure going to progress no matter what kind of dietary, nutrition, lifestyle, functional medicine approaches you take. It's not curable. And she's like, I totally understand that. I just want to see if I can function better and have less off days and potentially look at strategies to slow down the progression of my disease. And then I made it very clear with her that, it's very hard to determine if the things you're doing are slowing down your disease because you're going to progress no matter what. Theoretically, you might progress slower if you incorporate some strategies that have been published in literature that may impact the neurodegenerative disease process, but you're going to for sure 100% have progression of your condition despite everything that you can do with that nutrition lifestyle. And she understood that. Now, she had some recent tests done. She had some Cyrex lab tests done. She's concerned about some possible autoimmunities, immune reactives to multiple pathogens, intestinal permeability with LPS, blood-brain barriers in the equivocal range, which is one standard deviation. We'll go over those tests. It's in her file. Then she's worried about metabolic issues like insulin resistance and faulty mitochondria. So you can tell she's well read on the subject. If she's talking about faulty mitochondria as a patient with Parkinson's disease, then she's definitely done some reading on her own and is educated in mechanisms that could be used. Now, if we look at her list of medications here, you can see here she's taken telmisartan, which is a angiotensin inhibitors for high blood pressure. She's taken levodopa. Levodopa is basically synthetic dopamine. Synthetic dopamine is able to cross the blood-brain barrier. Actual bioidentical dopamine can't cross the blood-brain barrier, so she's on levodopa. And when people start taking levodopa, especially for several years like she has, they can develop something called tardive dyskinesia. So if you ever look at Michael J. Fox and you see him like moving around and doing all these things, that's not from the Parkinson's disease. That's a side effect of highly sensitized dopamine receptors from the medication over time. So we have to see if she's got any tardive dyskinesia. She's taking Azilect. Azilect is the first drug that she was placed on. It's typically a first drug people use for Parkinson's disease. It's an MAO inhibitor. So monoamine oxidase is the enzyme in the biotransformation pathways of the liver to clear out dopamine and epinephrine and norepinephrine. So taking this drug is commonly used as a first-line therapy for Parkinson's, so they can have dopamine hang around the synaptic cleft longer by slowing down its breakdown. And it's very common to see levodopa with an MAO inhibitor at the same time to optimize the effect. She's on estradiol, she's on prometrium, she's on trazodone for sleep, which modulates the serotonin pathways. So she definitely has some neurochemistry mechanisms involved. So she's taking levodopa. She's taking an MAO-based inhibitor. She's on blood pressure medication. She's an angiotensin 2 inhibitor, and she's taking hormones. So there's a lot of things that are going to impact her neurochemical function as we go through it. Now, if we take a look at the supplements she's taking thiamine, riboflavin, B12, methylcobalamin, and magnesium, L-theanate, D3, D4 alpha-lipoic acid, sodium butyrate, melatonin. I'm not sure what she's taking some probiotics, liposomal glutathione, berberine, vinpocetine. So her B's, her magnesium, some antioxidants, some butyrate for her microbiome, which is pretty advanced. Most functional medicine people don't use those, but she's definitely worked with some people that have come to some of my education seminars. So she's had some implementation of some of those concepts. And vinpocetine for blood flow and circulation, berberine most likely for blood sugar management, and this is probably why she's writing insulin resistance issues here. Okay, now I highlighted some things, as you can see, that I thought were important to discuss as we go through her case review. And obviously you want to read the case review for yourself and pick up on things that you think are relevant and important as you evaluate her case. Now, when we look at her family history, she says her maternal grandmother had tremor and was diagnosed as Parkinson's. And she had head tremor. Now, head tremor is not Parkinson's. So head tremor, like when people have head tremor like this, that's really essential tremor. That's a cerebellar disease. It's many times a genetic familial cerebellar disease. And essential tremor itself is a cerebellar disease, so it's not necessarily Parkinson's. Parkinson's is a resting tremor. Now, Parkinson's people don't get head tremor, they actually get lip tremor. So if you ever see lip tremor, you think of Parkinson's. If you see head tremor, you think of cerebellar disease. If you see essential tremor, which is tremor with movement, then you think of cerebellar disease. Then her mother was diagnosed with restless leg syndrome and high blood pressure. And most likely, if she has high blood pressure and type 2 diabetes, a restless leg syndrome is from like a mini infarct. And mini infarcts that involve what I call the lenticulostriatal arteries, which are often the medial cerebral artery, can lead to little mini strokes that then cause the restless leg syndrome. So that's most likely not related to a neurodegenerative disease. And then she goes, as a child, she got better after her adenoids were removed. She had strep throat during her childhood. These are important because, strep antibodies can bind to cerebellar tissue. Parkinson's disease is cerebellar disease, so there could be some past injury influence as part of the many layers of that stuff. Obviously, this is not the cause of her Parkinson's disease, but just something that's important to remember from her history. And then she says that her first chronic health problems emerged in year 2000, 1998, 2000, so over 20 years ago. She has difficulty with sleep and elevated blood pressure. Now, you should know that for Parkinson's disease patients, one of the first signs for some people that develop it is they have difficulty sleeping, and they usually thrash all over the bed, and they get to the point where they can't even sleep with their spouse because they're flinging their legs and almost hitting people. They're very, very active in their sleep with movements. So this may be something to that. What was her first presentation? We don't know if it was sleep related to restlessness and movement. She may not be aware of that unless someone was taping her or her spouse told her that he's getting beat up sleeping with her. And then elevated blood pressure here. And then she had persistent high blood pressure. And then around 2004, she still considers herself a healthy person with good athletic capacities. However, started to notice that started noticing some loss of fluidity when I was walking. So loss of fluidity when I was walking is probably when her rigidity started to come in. So with Parkinson's disease patients, they don't start with tremor in 90% or plus of most cases. They start with stiffness, rigidity, insomnia, constipation, and loss of smell. So those are the first things that they have. And this is because the alpha-synuclein, which is in Parkinson's disease, what happens is the protein aggregation of alpha-synuclein, and then these alpha-synuclein bodies get surrounded and develop what's called a Lewy body, and then these Lewy bodies get in the way of normal synaptic activity. And it starts in the enteric nervous system and in the olfactory bulb. When it starts in the enteric nervous system, they usually have constipation first. When it gets to the olfactory bulb, they lose smell. In particular, anise, peppermint coffee, or the initial smells that research has shown that they lose. And with time, they start to have areas of the basic ganglia start to degenerate, and they start to first have stiffness and rigidity. So when she's losing her fluidity of movement, this is probably her Parkinson's disease impacting her muscle tone here. And you can see progression 3 to 4 years later. Sometime around 2008, I started to have pain in my left arm, sometimes tennis elbow, carpal tunnel, and made numerous visits to chiropractor with temporary relief. And this is really, really common. So as people develop Parkinson's disease, they lose their fluidity, they start to get more tight than usual, and it usually starts in one limb. It's not their entire body. And some people, it's a frozen shoulder. In her case, it was a tennis elbow. So she gets increased tone of her elbow, and they can get treatment after treatment after treatment to treat it and get massage. That can release some of the muscle tension and lactic acid and give them some temporary relief, but it just will not last. So sometimes it's neck rigidity. They go and see a chiropractor forever. Sometimes it's a tennis elbow or carpal tunnel. They go and get physical therapy, massage, acupuncture, anything they can to relieve it, but just nothing really fixes it. That's always a red flag for early Parkinson's disease. Okay, then 2009 had first occasion frozen left shoulder, so there you go. Now it's going, from left arm tennis elbow into the shoulder, right? And then frozen shoulder for a period of time. X-ray shows some calcium deposits. So she's not moving her shoulder's getting inflamed. They give her some steroid injections. Calcium deposits. It's, for many people, by the time they get older, they'll have some calcium deposits in some shoulders, but that's not the cause of her frozen shoulder. The cause of her frozen shoulder is muscular, right? So lack of movement, of muscles being tight, rigidity. It's not going to be caused by calcium deposits, but we have a healthcare system that doesn't understand that. So she was just given steroid injections. They're obviously going to, loosen up things, reduce inflammation. Okay. Then she was diagnosed with the akinetic rigid phenotype. In the absence of tremor, not having a clue that frozen shoulder in combination with other symptoms indicate beginning of Parkinson's. So akinetic, rigid just means they're just stiff and unable to move very well. And akinetic means they may not move at all. They may have some freezing. So that's what we're seeing here. Now, there's no tremor. So remember, tremor is one of the last things to show up with Parkinson's disease. So for people that are waiting for a person to have tremor to make the diagnosis, they're going to miss majority of Parkinson's disease patients at early stages where you can have the greatest effect with, preventive medicine approaches. Then she goes on to say, continued feeling unwell without understanding what was going on. Second encounter of a frozen left shoulder happened in 2011. Cortisone injections had no effect this time. Of course, they won't. Finally, after a few bradykinesia episodes, brady meaning slow, kinesia, slow movement episodes, she's starting to get slower with her movement. The air became so dense, suddenly I was moving through the water. I paid a visit to the neurologist in May 2012. So now she's noticing she's just not moving very well. Head and cervical MRIs were done. Also, a dopamine uptake scan was done, which showed diminished dopamine uptake in the right brain. So remember, the right brain is going to impact the left side. So you can now see the left frozen shoulder, the left hip, all being involved. They did a dopamine scan, which is a confirmatory test for Parkinson's diagnosis, and she's not having dopamine uptake in that area of her right brain. Then she's having those left-sided symptoms. So she goes on and gets further testing done, and they found the LRRK2 mutation, and this means that it's familial Parkinson's disease. So this is leucine-rich repeat kinase mutation. It's one of the common mutations people have when they have a family genetic susceptibility to Parkinson's disease. So when you look at Parkinson's disease, sometimes you have idiopathic, where like something destroys the basic ganglia, like some kind of toxic chemical can really destroy the basic ganglia, and they can get Parkinson's disease develop. And then you have these genetic mutations in which environment like chemicals, infections, pathogens, various factors can turn on these genes. They're turned on by multiple triggers. And and then they develop Parkinson's disease. So she has some genetic susceptibility for sure here with this LRK2. So the diagnosis is pretty clear from this. And then soon after she was diagnosed in June 2012, she started the Isolect, which is the monooxidase inhibitor, which slows down dopamine uptake. And then she was then added 2014 Nepropatch. And Nepropatch is basically a dopamine agonist, and that's done just to improve symptoms. Now, they usually don't jump into levodopa because levodopa can cause that tardive dyskinesia and cause other side effects, and so they wait for someone to be extremely rigid and stiff before they typically start with levodopa. So you can see the progression from an MAO to a dopamine agonist, and then in 2015 it became difficult to manage Parkinson's disease, mostly rigidity and bradykinesia, without dopaminergic medication. And the neurologist then started her on levodopa, so in 2015. So now we know she's on levodopa for over 7 years of using it. So usually people, the longer they stay on it, the more side effects they get over time. But it's one of the only things that really helps their rigidity. And for some people, it's the only thing that helps their constipation. They can have bowel movements when they finally start dopa. Now she doesn't appear to have any motility issues, but she's on the medication. Medication she's on levodopa. Though I started developing dystonia a couple of years after levodopa, it was manageable at first. And sometimes when people go on levodopa, they get tardive dyskinesia, and sometimes the dopamine increases sensitivity to those receptors, and they start to develop dystonia, which gets much worse. Okay, around 2019, off time became a real problem. So off time means the medication is just not working. Off time became unpredictable, longer, and often quite debilitating with strong and painful dystonia. So what's happening in her off time is meaning the medication's not working. She's getting severe rigidity, and what happens is the muscles and joints just get stuck in a position, and it's just like the muscle was contracting all the time. They get lots of lactic acid buildup from that chronic muscle contracture, and they just get pains. It's very painful. It feels as if my body parts, feet, legs, necks are all twisted and now to be torn in my body. So this is really important here because she's saying she's getting dystonia throughout her whole body. And that's not a good sign. That means there's some significant progression. If you remember the brain, there's the homunculus, the somatotopic map, where you have like the lips that are really big, and then the face, and then the arm, and then the legs. So if she's having dystonia in her arms, feet, leg, and neck, that means there's some significant progression of that Lewy body alpha-synuclein buildup in her brain. I developed diphasic dystonia, which manifests when dopamine level is low and dopamine is on the rise. So if she has too much dopamine or not enough dopamine, her dystonia gets worse. And this is where that Goldilocks phenomenon comes in, where you have to really match that dopamine level perfectly. So we see that that's happening with her. And then she goes on to say, the symptoms constituting off periods were strong rigidity, which is just muscles are super tight, bradykinesia, which is slowness of movement, and dystonia, which is like angulations. It appears that it's angulations throughout her body. A mild dystonia caused extreme rigidity, muscle spasm, and kinetic state, while strong dystonia manifests as involuntary muscle spasm that turned my limbs into unnatural positions, which such strength as they were going to be thrown out of her body. So one of the things we have to realize is that we don't know what we're going to get with the physical exam appointment. She may come in completely akinetic, rigid, and frozen, or she may come in and be like in a dystonic posture, or she may have an on period where things are working well and she doesn't have any presentation of any of the things that she's discussing. So, you have to realize that, when we get to the physical exam, how she presents will be a snapshot of what she's dealing with, on any given day at any given time. So she has this, 2019, so now the past 3 years, her medication just isn't working as efficiently as it was in the past. Okay. In 2020, 2021, my quality of life plummeted significantly. Off periods became longer and less predictable. On bad days, I could have been more than 50% of the time. So half of her life, she's in off time, which means she's really stiff, rigid, in pain. She has dystonia, despite taking medication. And if she takes too much medication, everything actually gets much worse. If she doesn't take medication, then she still has the dystonia. She's trying to find that Goldilocks period. I thought that these off offs were the result of disease progression and increasing dopamine deficiency, and kept boosting the amount of levodopa to 600 to 1,000 milligrams of levodopa, less on good days and more on bad days. Such boosted levodopa resulted in more severe side effects, more brain dysregulation, and increasing levodopa intolerance, and severity of biphasic, meaning too much or too little, strong dystonia with strong and very painful spasms. Dystonia struck with low dopamine and very new pill for levodopa while the dopamine concentrations are on the rise. Needless to say that my life became a nightmare due to dystonic pain. I was afraid to go outside the house due to unpredictable of these attacks. Now, when you look at any kind of case, you're trying to figure out what could be a realistic outcome and a realistic goal. So it's not going to be realistic to cure Parkinson's disease with preventive medicine, functional medicine. There's actually no cure for Parkinson's disease. So, if her off time is 50% and we can reduce it to 30% or 40%, that would be clinical success. So she could have less of these off days, instead of half the time, a third of the time. That would be dramatic, and that would definitely improve her quality of life. So as we go through the history and have discussions with her, we're going to have to figure out what's going to be some realistic approaches we can do to manage her case. Okay? Now, if you go in there and go, oh, we're going to get rid of your heavy metals, and we're going to treat your parasites and fix your microbiome, and we're going to reverse your Parkinson's disease, you're just naive. That's not how things work. And you're going to create false hope with the patient, and it really is just completely due out of clinical incompetence that someone would say something like that. So what could be realistic is maybe impacting your off versus good days, having her have more energy, having her have more endurance, having her have more resilience to things that bring on her anxiety and tremors as her brain function improves. But that's something we have to pay attention to as we go through the exam and develop a treatment plan. And then she goes on to say, I did not have constipation, which was considered to be one of the first symptoms of Parkinson's disease for my initial PD symptoms in 2008 until the end of 2019, through the beginning of 2020. So the combination of poor levodopa absorption and constipation and growing number of papers regarding alterations in PD patient's microbiome and discovered the bacterial species in the gut thriving levodopa, just looking at the gut. So she's been reading up on Parkinson's disease, obviously, and she wants to not ignore the gut, which we definitely will not do. In January 2020, I submitted blood samples to Cyrex, so she must be working with a functional medicine practitioner at this point. And she does Array 2. And Array 2 shows that she's out of the range for IgG. She has endotoxemia. She has intestinal permeability. We'll look at those tests a little bit later. Some wheat reactions, some reactions to the foods. So, gluten, food sensitivity, leaky gut is part of the pattern that she's with. Obviously, it's not going to be the cause, but it can be an ongoing inflammatory trigger. And the more inflammatory trigger she has, theoretically, the faster the progression of the condition. So then we can see, she's on levodopa. 2020, pretty much the same variation, some good days, who can function pretty normal on days. She's just talking about how her medication doses changes. And then when she's on an on state, she's doing very well with 5% of Parkinson's disease patients who manage to preserve all functions. So she can be really be in a good on state and seem like she doesn't have any symptoms at all. Now we'll have to see how she presents with the exam so far. And then in December 2020, she had some blood samples done with Cyrex. We can go over the results. She lists them out here, but obviously she's reacting to food. She's got some chemical reactivity. She's got some past antibody reactions. She's got some blood-brain permeability, intestinal permeability. And that might not be the first place to start with her. We have to kind of look at the big picture and see what's appropriate. And then it was clear I needed some serious help. I already had a attempt to the Khwarazmi clinic. Yeah, with my practice, as many of you know, and like many of you, we get so full, and then we have to close or practice for a while for new patients. Then we open it up again to play catch up. And I think she contacted us when we were just playing catch up, but we were able to finally get her in. So she's considering doing a paleothalectomy, trichotomy, which is basically like a cyber knife where they can go in there. It's a new procedure for Parkinson's disease. She's still considering that, it seems like, in her history, but she wants to look at other approaches and I guess consider that in the future. So she's making some lifestyle modifications. She's gluten dairy free. She's working with some functional medicine practitioners. She's trying to make some changes to her brain. She worked with some practitioners that do functional neurology and functional medicine in the Bay Area, which they did some strategy with her. They started to do some eye movements with her, and eye movements actually activate different areas of the brain, including raising things like catecholamines and dopamine and serotonin in the brain when you activate eye movements. And she had some dramatic improvements, but then she significantly crashed. This happens when you jump into like a neurological rehabilitation program when mitochondria are unhealthy. So she had some of those patterns, and then she experimented with different diets. She started with grain, dairy-free, no fruit, sugar, transitioned to a keto diet, gluten-free diet, was feeling okay. Sugar was not easy, real insult to the brain, started sabotaging the process, and then she became very rigid and akinetic when her blood sugar levels dropped. So and then you can see here she's having some issues with her diet and getting fuel to her brain. She's interpreting it as mitochondria, which is probably accurate. So she started to fuel the brain with ketones. I used to be on a keto for a limited time, but 10 years ago I enjoyed the experience. The time was a disaster. Her body couldn't digest fat. So she's having some problems going to a ketogenic diet. We got to figure out what those problems were, because if she can get into a ketogenic state and run on ketones, she can function much, much better. And her mitochondria can have more efficient precursor energy sources than if she's using glucose. Just some heart palpitations. And then she goes through and basically, describes some of her on and off days that are visibly worse. And she goes on to say her balance is very bad when unmedicated. There were balance issues. We got to see if she's got any issues with the vestibular system. Cerebellar disease is a possibility. That alpha-synuclein buildup does impact the cerebellum, so she could have degenerative changes there. So we have to be conscious of that. Then she lists her diagnosis, which seemed to be pretty accurate. High blood pressure, 2012 Parkinson's disease. And then on and off states. She starts to get dystonia. And then starts working with some functional medicine people, leaky gut, maybe leaky brain, autoimmunities. And as you go through the report, you can see some of the things that she mentions here. And then here's the very important portion of the case review file. Please list any treatments, medications, supplements that have improved your health. This is basically them, reminding us and telling us how to treat them, how to help them. And sometimes people forget things that have helped them in the past, and you have to remind them that these things can be very effective. Now, obviously, the levodopa made a big difference, which it does with all people with Parkinson's disease. And one thing you should know is that when people develop Parkinsonism, which is like rigidity and stiffness, tremor, they may have Parkinson's disease, or they may have what are other neurological diseases of the basic ganglia, like cortical basilar degeneration, multiple system atrophy, or supranuclear palsy. And one of the key ways that distinguishes whether they have these other types of Parkinsonian diseases, but not Parkinson's disease, or other types of basic ganglia disease, is if they respond to levodopa. If they respond to levodopa, it strongly suggests that they actually have Parkinson's disease, the classical type. If they don't respond to levodopa, and that doesn't change any of their symptoms, it's more likely they have something like multiple systems atrophy, which is terrible disease, which is a disease where they start to get autonomic changes and they can lose their respiration, basically suffocate, and they usually have a very bad prognosis with multiple system atrophy. The lifespan is very, very short, just a few years after diagnosis. And there's supranuclear palsy, which also has a terrible prognosis, and they start to lose vertical eye movements, but they don't respond to dopa. Then you have cortical basilar degeneration, where you start to have more dementia-based symptoms and so forth. So the fact that she responded to levodopa rules out that she may have some of these atypical Parkinson basic ganglionic disease, which is a really good sign. Now, intense physical versus physical activity, this is critical. One of the things that's clearly published in the literature is physical activity, especially complex motor movements like boxing or movements with arms and limbs at a fast, rapid, explosive pace can raise dopamine levels. So she's noticed that herself. And then she thinks eye exercises are very powerful, very helpful, yes, but you gotta have some integrity to do those. And then we look at here, cause adverse reactions and things that, we definitely don't want to do. And, one of them was the eye exercises, and then she lists some of the medication she had some adverse reactions with. So here's a list of all the medications that she's been on, and you can see she's been on stuff for blood pressure medications and hormones, and then basically things to modulate her dopamine levels, things to modulate mood and depression and sleep. 2012, she had the confirmatory test for reduced dopamine uptake for Parkinson's disease. And then, those are the main things from her history. You can read more, but those are the things that I thought were really important, the highlights. Then we look at her brain health nutrition assessment form. Section 1 is just related to circulation. Poor nail health, nail buds are white, so we want to see what her circulation is. Obviously, at this point, we're not going to be able to do anything or treat Parkinson's disease, but we can do things to improve her mitochondrial function, to improve her general brain health, and see if that makes an impact on her brain endurance and her on and off days, and her resilience to emotional triggers and cognitive triggers that make her tremors worse. So poor circulation means there's not enough blood flow going to the brain. So this is something we want to consider and look at strategies for that. Crave sugar and sweet in the afternoon, wake up in the middle of the night. These are hypoglycemia symptoms. That can definitely make all her symptoms turn on and can make her have more bad days. Difficulty losing weight, frequency urination, difficulty falling asleep. These are symptoms of cortisol patterns that may be there. But, when people take MAO inhibiting drugs, their catecholamine, epinephrine, or epinephrine high. That can make their cortisol levels spike up reflexively as well. So let's see what's there. And then here we have dry, unhealthy skin, dandruff, flaky scalp. These are symptoms associated with essential fatty acids, so she may not have enough healthy fats in her diet. Constipation or consistent bowel movements. It could be some of that degenerative changes taking place in her gut nervous system. Or maybe dietary related. We have to see what's there. She's on a 100% gluten-free diet. She knows grains and gluten causes symptoms for her. She's been diagnosed with gluten sensitivity. Look at section 10, overwhelmed with ideas to manage, feelings of dependency on others. And overwhelmed with feelings to manage is one of the things that causes her anxiety and also brings on her symptoms. And then these are all symptoms of low dopamine, feelings of worthlessness, hopelessness, self-destructive thoughts, inability to handle stress. These are what happens when dopamine levels are low in the brain. And then feelings of nervous or panic for no reason, restless mind, and that's the basal ganglia. There's the basal ganglia limbic loop that dampens your that dampens your limbic system so your mind doesn't go crazy. And people that have basal ganglia disease will many times have these restless minds. And if your frontal lobe can function better, then that may make some change here. Now, when we look at her symptoms here, there are some slight the brain region localization form. There are some symptoms of the frontal lobe. Obviously, when you look at these forms, you want most people to have no symptoms. When you start to see 3s and 4s, you're really concerned. 2s, you definitely want to keep a look on. She has lots of 2s here. 2s means she has the symptoms half the time. So half the time she has emotional instability. Half the time she has difficulty. She has constant repeating events or thoughts with difficulty letting go. That's called perseveration. They just can't get a song out of their head. They can't do things. You may have experienced that yourself if you've ever had like a fatigue of your frontal lobe. But those are the patterns there: depression, mental fatigue. So her frontal lobe isn't very healthy. And then here you can see the 4s all the time. These are just related to the motor cortex, meaning the way it works is your cortical spinal tract causes you to be able to, with your frontal lobe, to have movement and function, but your basal ganglia indirect pathway calms everything down. And if it can't calm everything down, these are the D2 receptors, you get rigidity and tightness. So all these are really rigidity and tightness are due to not so much the frontal lobe, but the striatum, which is part of the basal ganglia for that dopaminergic pathway. And then, you can see, again, some symptoms here. She's got some significant cerebellar symptoms, which is involved with balance and stability. We also know gluten ataxia can cause some of those patterns. She's got some dysautonomia patterns as well, which is not uncommon with people that are on some of the medication she's on, and even with Parkinsonian disease expressions. And then, when you look at the spontaneous symptoms here, basically it's just increased muscle stiffness, rigidity, dystonia, and anxiety and emotional responses, which she has some spontaneity in. And then we look at the metabolic assessment form. She's got some coated tongue and fuzzy debris on the tongue, so we'll have to look down the physical exam. That just happens when the gut microbiome is not functioning very well. There's some excessive hair loss that can happen with insulin resistance. We're seeing some symptoms of insulin resistance here. That can definitely be a trigger or a variable that promotes neurodegeneration, makes mitochondrial function inefficient. She's got some adrenal, aldosterone, electrolyte imbalance symptoms here. The craving of salts, so slow in the morning, muscle cramping, poor muscle endurance. Some of those are most likely low to muscle tone, so we'll have to see what's going on with that. And then she's got some symptoms of hypothyroid and maybe even hyperthyroid, but these may just be neurological based and essential fatty acid issues that may cause skin issues. So, on our lab work, we didn't see any signs of any clear thyroid disease. Okay, and then we can see again on this form, neurotransmitter assessment form, basically clear hypoglycemia symptoms, inability to handle stress as the main things there. And then we'll look at some of the imaging and lab studies she sent with her file. And this is MRI head without contrast to validate for Parkinson's disease. This is back in 2012. And what they found here was normal volume of the tegmentum. The tegmentum is the area of the midbrain where the dopamine centers are, the substantia nigra, and brainstem, and no evidence of asymmetric atrophy or abnormal iron deposition in the putamen to suggest progressive supranuclear palsy, multisystem atrophy, or corticobasal degeneration. So these are the atypical Parkinson's disease patterns we're looking for. So this is, something that's pretty obvious at this point, but she doesn't have, with multiple system atrophy, you get some degeneration in supranuclear palsy, you get degeneration in the midbrain and brainstem, and with corticobasal degeneration, you get degeneration in the frontal lobe. And there's also some people that have iron depositions that lead to Parkinsonian disease development. Iron depositions destroy the basal ganglia, in particular the putamen. So they're saying we don't see any of those patterns that are there. So they're just ruling out other causes for Parkinsonian symptoms. And then they do the dopamine uptake test. And with the dopamine uptake test, they clearly see that she has diminished uptake of dopamine on the right side of the brain. And, that confirms a diagnosis. So this was back all in 2012. So about 10 years ago. Now in 2020, she worked with some functional medicine practitioner. They identified leaky gut, not only just leaky gut, but she also has endotoxemia. That's a terrible combination. So we know her gut barrier is causing inflammation throughout her body. She has some reactions to wheat. No clear patterns of celiac disease that are there, or transglutaminase 6, which is something you see with gluten-induced cerebellar ataxia. She doesn't have those patterns. Then she has some selective reactions to foods that are showing up there. Here with array number 4. So, and she knows she can't handle wheat. She's been on a gluten-free diet at this point, but she doesn't have a clear pattern of celiac. And then here you can see her hemoglobin A1C. She's within the normal reference range. Her glucose is, within the normal reference range. And then these are just, vitamin D levels are 43, it's within normal ranges. We'd like to see those functionally above 50. T3 levels were measured. They're within the normal reference range. We'd like to see these maybe functionally a little bit higher, but it's not a very stable marker. Here we can see free T4 within normal reference ranges. TSH is the one we're really concerned about because that lets us know if she has thyroid disease, hypothyroidism, that can impact her Parkinson's disease function. Thyroid hormones have a direct effect on dopamine receptors, so you definitely don't want a Parkinson's disease patient to be in a hypothyroid state. So here she doesn't seem to have any issues there. Her electrolytes are okay. Her BUN was just blood urea nitrogen, just 1 point high with no other signs of renal disease, so that's no big deal. Glucose fasting is a little bit high here. No, I'm sorry, fasting glucose was a little bit high before, so she has some patterns of insulin resistance, but her HbA1c is not elevated. Slight elevation of total cholesterol with her routine lab work. And then if you look at, she's been tested for H. pylori, not detected. Just through the rest of the routine blood chemistry panels, there was nothing significant. And then when we look at array 5, that was done in 2020, She has some intrinsic factor antibodies, which means she has risk for developing B12 deficiency and B12 anemia. That's something to look at. And she has some neurological antibodies to cerebellar protein and synapsin. So a lot of times when people develop neurodegenerative diseases, those protein aggregates start to have antibodies develop against them, and there's an antibody response against them, but it may not necessarily be neurological autoimmunity. Or you can have both. It's hard to distinguish just with the antibody test. And then here, it's just the array 10, looking at foods that she's reacting to. So she hasn't lost total immune tolerance. This is really critical. People that have autoimmune diseases and people that really have immune dysfunction, they start to test for almost every food. And that's a loss of immune tolerance. She just has some selective foods she's reacting to, but it's not a complete loss of immune tolerance. So that's a good sign. And then she doesn't have any reactions to chemicals. This is array 12, where they look at past antibodies. And to be quite honest, I'm not a big fan of this test because many people have these antibodies. These are IgG antibodies, and they can last for many, many years. It just means past exposure. Now, if she has any kind of viral and immune responses, we're going to see some shift in her immune panels, her T cells, B cells. We can look at her immunoglobulin levels a little bit more and see she has underlying patterns of infection, but these could just be past exposures. They don't diagnose an active infection. Here we see some blood-brain barrier permeability. And then this is just a routine metabolic profile. And if you look at these numbers when you get a chance to go through it on your own, you see there's nothing really significant there. Fasting glucose is a little bit, always above 100, a little bit of insulin resistance patterns there. CRP level was high here, 3.4, slightly elevated. Some subtle inflammation there. Homocysteine levels were 7.8. Now, anytime you have a patient on levodopa, you've got to really make sure homocysteine measurements are measured because levodopa can deplete methyl donors. And with her levels are fine. But, a lot of times people will have, someone like her, she could be on levodopa. As she continues to increase her dose, she can deplete her methyl donors. Homocysteine levels go up. She already has hypertension. And then the combination of hypertension and homocysteine can then lead to vascular insults. So in the literature, there's many cases of people that have been on levodopa for a period of time, and then they start to get vascular insults and then have Parkinson's disease, then promote vascular dementia patterns. So there we're okay. Now here, we're seeing the TSH slightly up, but it's still within the normal reference range. Something just to keep an eye on. Then we go through methylmalonic acid measures B12. Remember, she has intrinsic factor antibodies, which means the carrier protein for B12 is impacted. However, methylmalonic acid, which is really the most sensitive test for B12 function, B12 levels, is within normal levels. So even though she has intrinsic factor antibodies, it's not expressing enough to the point where she can't absorb B12 yet. And then if you look at her immune function, like her white blood cell count, and if you look at her neutrophils and her lymphocytes and basophils and eosinophils, even though she had some past antibodies with that Cyrex array 12, it doesn't seem like she's dealing with an active infection. Now, if you want to go deeper, you can look at a T and B cell profile. There's no indication that's there. And then she has an essential fatty acid profile done. And basically, she has high amounts of EPA and DHA, probably because she's supplementing with them. And her arachidonic acid levels are high. That's coming from shellfish, red meat, things like that. Okay. And then this is just a neurosurgery report. You can read on your own. And the rest of the case review is basically just routine panels. Again, TSH is normal there. Thyroid antibodies were checked. They were normal, That's important because sometimes people have these antibodies show up before they develop hypothyroidism where the TSH levels can fluctuate. And then the routine lab work doesn't show anything that is significant. Vitamin D levels are always in the 40 range. You can be critical on improving. Homocysteine levels are still within normal. We want to keep an eye on that anytime someone's on levodopa. CRP levels here are elevated. So this is in, 9/1/2021. She's got some inflammatory reactions happening in her system. Now, hemoglobin A1C is starting to pop up out of the normal reference range in 2021. She's getting into that, insulin-resistant pre-diabetic pattern here, right on the border, and her average glucose is 114, so that's going to play a role in promoting neurodegenerative processes. And then she has electrocardiogram done. She has no signs of any type of ischemia or any problems with her heart electrical activity. Everything's normal. Chest x-ray, no evidence of pneumonia. This must be when she probably went to the hospital for chest pain, and they did a chest x-ray, did an EKG, and checked her troponin levels. All of that appears to be normal. And sometimes chest pain is just significant rigidity against the chest muscles. So that's important to check. And then check their D-dimer. Again, probably worried about clots or at that point. Okay. So those are the main things from her case review. If you get a chance to look at it on your own, you can see what's there. Now, anytime someone has Parkinson's disease, we want to look for a few things in the physical exam. Is she coming in on an off day or on an on day? Does she have any tremor? Does she have any lip tremor? Does she have any hand tremor? Does she have any leg tremor? Where's her dystonia? Is it a cervical dystonia? Is it hand dystonia? Is it leg dystonia? Does she have hypomemia? Hypomemia means that her voice gets really soft. So people that have Parkinson's disease sometimes are soft. They get their voice to become soft, especially as the brain gets fatigued. Want to see if she's got any mask face patterns. One of the easiest ways to find mask face is that just don't have proper blinking. So we want to see if she's blinking regularly throughout the exam, if she has normal facial contractures and tone. So we want to be looking at those things. We want to see how she walks. We want to look at her muscle tone. Those are all the key things we want to do based on her chief complaints. So those are the main things with Svetlana's case review. So at the end of the day, we have a patient that's suffering from Parkinson's disease, and we want to look at some risk factors and variables that can make an impact on her general health, and maybe some things we can do to improve her brain function. And she has off days 50% of the time, and if she has to take her medication. If she takes too much medication, she gets much worse and has severe spasms. So she's trying to figure out that Goldilocks type response, and she's got some panic anxiety, and anything that kind of stresses out her cognitive functions tend to promote that. So I hope this video helps, and when you get a chance, please review the case review in detail for yourself, and check out the physical exam, and we'll look for these variables and mechanisms in the physical exam.